And recognize our remote participants as well. Hi, everyone. I'm Ashutosh Shukla, and I just wanted to welcome everybody to the grand round. There are going to be a few disclaimers, so please bear with me for going through them. You will get this code over there as well as here and multiple places, so you should be able to scan through my incoherent talk today throughout the next 1 hour. One of the things that I do want to one of the things I do want to say that I don't have any financial conflict of interest, but I do have a point of view here. So if you find me strongly for or against something, I hope not, but you understand that it is within the context of some of the things that I do. And this is more of a, I'm not trying to sell a point of view. I'm not trying to sell a conclusion. I'm trying to sell an approach. So I think there is a little, I just want you guys to give me a little bit width on that. This is the other disclaimer, so please bear with me. I don't have that declared on every single slide. What we are going to do this is the classic CME version that I have sort of sent out with the talk, but what I do want to send disclaimer with this objective is that these. This is to some extent, and I've been I've been debating myself whether I need to have this style lecture. And my worry was, considering that I'm neither funny nor a good orator, my worry is that this may come down as a balloon dropping on a ground and making that sound at the end.
Well, sometimes disasters are interesting.
Correction, disasters are always interesting as long as they are not happening to you. Unfortunately, today, this might be happening to me. So the other part which I would say is that you might find the talk not progressing well, especially, I don't know if it will or not for you guys. I think in my head, it's very clear. But the last slide probably will tell you what I was talking about all along. So for those who cannot stay till the last slide, this is the talk. And this is a more normal way of looking at the talk. How do we adjudicate causality or casualty, whatever you want to call? You all know the joke, but causality in complex systems. Okay, and that's the primary question. So in other words, every day we go through this in our hospital. We hardly ever find clean enough data that we can clearly say, this is the patient, this is what I need to do. And we make these judgment calls every day. What drives us making that judgment? And what I want to say here is that, and this is the answer, that you examine carefully the known knowledge and a priori articulate plausible hypothesis, and then you understand the limitation of your findings or the limitation of your decision. So this is sort of saying what I want to say over the next hour. But let me tell you in a more complicated way. What we are going to do is we are going to use an example of a 40-year-old topic. That is, and for this lecture, KRT means dialysis. I'm keeping out of transplant. There is a whole discussion to be had, keeping out of conservative care, and I'm also keeping out of home hemodialysis as a perspective. I'll lump it together as home dialysis. But generally speaking, I'm trying to do here is compare dialysis modality. And for anybody over the age of 35 in this room, which almost only 2 or 3 people are there like that, you all know we are all tired of this topic. We don't want to discuss this topic. In fact, today is year 23 when I first presented this topic. So I have presented multiple ground rounds on this topic. So I don't know whether I'm doing something new or this is just an old coming up with a new twist. But as you know, we have a lot of publications trying to say which dialysis modality is better. And for the sake of this, I'm just home dialysis and PD is interchangeable, PD versus HD. you can go to every one of you in this room has an opinion on this. Every one of you on this room has an opinion on which subgroup it works or where it doesn't work. No, I know this answer, or I know the limitation. We can have a discussion on that just in open forum, but I don't need a slide deck for this. Once you look at the cohort, you look at subgroup, and people have done this, and this, you don't really have to read through this, but essentially what I'm trying to say is there are multiple subgroups that people have shown for which this may or may not work, and they have strong position. In fact, in early 2000, up till almost 2010, we used to have people coming up with strong positions that I think this is this, okay? And I'm not sure how many of those conversations I walked away completely defeated because I had no way of communicating what I was saying. So this is a terrible or tough discussion. What we decided about 10, 12 years back is we need to stop talking about it. And the reason why we stopped talking about it is on the left side. These are relatively contemporarily closely published paper together. The left side paper says that if you compare mortality in an unadjusted method, you can show home dialysis to have better mortality. But if you adjust for all the things under the sun, and that depends what all you are adjusting for, there is no real difference between home and in-center. Compared to this, you see this particular paper from a very well-known group, and they said even after adjusting, the mortality is better on home dialysis. I'm telling you, there is no way to conclude this. So we go with this particular dictum. Rajesh Malhotra, about the ASN Journal Editor-in-Chief, about 12 years back, Annals of Internal Medicine published and said, hey guys, let's stop talking. What I can tell you is there is a time-dependent improvement in survival for dialysis in general. He meant PD more than chemo. And across all time zones that I'm examining over the last 15 years, there is no difference in survival. And now you can decide there is a whole bit of controversy when you show equal outcome, what all you are controlling for. One of the classic arguments Joan Bartman used to have was that they would, on hemo versus PD, compare on HSCRP and inflammation marker. And Joan Bartman would get really upset on this, saying that if the PD is causing less inflammation, and if you're controlling for that, what are you doing here? So what you are saying is all my benefits are not my benefit, they are patient benefit, and then you are comparing my mortality. So again, what I'm trying to say is that I'm not going to get into this. What I'm going to go is this particular state of affairs, which I have been practicing for the last 15 years, which at the end of this lecture, I will still believe is true. So having said that, now the causality essentially means you ascribe a cause and effect relationship. In an alternate word, you could argue that even a comparative efficacy studies in some ways are ascribing cause and effect relationship, meaning thereby when we say one is better than the other, we are sort of adjudicating a treatment's cause into the effect of input outcome. So how do we do that? So let's take a small diversion and we'll look at the historical aspect. Historically, medicine has gone through various theories of causality. This is the oldest, this is from the land where I come from, and that's called karma theory. And the karma theory states that your actions and inactions of past come back to haunt, hurt, or reward you later. And it's a very holistic way of approach. The good or bad of karma theory is that it's so old that it has been interpreted and reinterpreted and reinterpreted so many times, like Bible or Gita is done. So that, such that there is a whole variation on that, which says that, we are not arguing against medicine. This is in and of itself a separate field that we are going with. So that's one way to look at it. But if you go to relatively the Western culture sort of realm, the initial one that one came was this humor theory. Now, I learned that humor, and I don't know whether it in Latin means that or not, but humor means fluid. And Hippocrates basically came up with, thank you very much for validating that. Hippocrates came up with this particular notion that these fluid anomalies of the body manifest as disease. And I think for all of us who come from very old culture, some of us at least, we know that we have heard this part, the bile and the phlegm and the blood and this thing. And to some extent, they were ascribed some sort of a personality, some strength and weaknesses, and you could ascribe individual these properties, and these properties could change. And that would determine what they are going through as disease, and the treatment would be based on that. So the whole causality in those era was as broad as that. And the reason why I'm saying is that we have gone through this period of causality, and people during this period believed that they were right? I mean, we went through the whole humanity. Somewhere in the 1800s, we were still practicing this, that, and a part of this, you have to remember, before modern medicine, was all infectious disease. Medicine was largely infectious disease, with intercurrent illnesses occasionally bothering you otherwise. So most of the diseases were concentrating, most of the theories were infectious disease, but they were broadly applied to infectious and non-infectious disease. And so the miasmatic theory was that it's bad air. If you live in a bad air area, you get disease. If you don't live, then it is good. And generally speaking, bad air means the one that smells bad. And we used to believe this till less than 200 years ago. So we are pretty much we have lived in this era more than what we are living in the current era. After that, the theory of contagion came, and this is the time when there was the true effect of scientific principles sort of starting to translate. This was primarily for infectious disease, and it went from air to touch mechanism. And then after this came the germ theory, where Louis Pasteur essentially established the principle of germ theory, which is that you can kill things inside a liquid. And if you keep the system closed, you won't have any problem. The germs won't grow. But if the system is broken, there is re-exposure to germs, which then again leads to growth of the germ. So this was the sort of, let's call it the semi-final theory. And then from this came Koch's postulates, which is a 4-step mandatory causality steps. And the 4 causality steps are: the agent is observed in all cases of disease and absent from healthy. And each one of them are important. Agent is able to be isolated in pure culture, or you can isolate the agent. Forget the culture for a second. When introduced into healthy, the organism experiences the same course and disease. And then again, the agent can be re-isolated from, so that once you cause the disease, you can re-get the agent back and do it. And this Koch's postulate pretty much drives clinical and medical science and discovery even today. So most of us, we have heard, I think some of us no longer talk, but if any one of you had seen Charles Wingo talking before, and my mentor, the Koch's postulate was very much the discussion for everything. And this didn't only go for the infectious disease. Koch's postulate then was transcribed for genetic disease, environmental disease, so on and so forth. So they always say that you can have an exposure, it will cause the disease. Take the exposure away, the disease goes away, re-expose it, the disease comes back, so on and so forth. So there was always a sort of a version of Koch's postulate that we went with. The problem is the Koch's has limitation. And the limitations are, so if you have a direct causality, which means A causes B, that's called direct causality. That means your exposure is sufficient and necessary. Necessary means without the exposure, you can't have disease. And sufficient means you have exposure, you have disease. Unfortunately, many of the diseases we know are not direct causality. There are a lot of steps between A and B. And during these steps, if you see an individual or a patient, you may not be able to either isolate an exposure or disease. And when these indirect causality, even though this is the causality, when there is an indirect causality, the Cox postulate becomes very complicated to be isolated. So that's your first problem with Cox postulate. It works wonderful in short term, but it doesn't work over a longer period of time because there are intervening events which complicate the matter. And the kind of complications that occur is you can have exposure is necessary but not sufficient. You need more than one exposure. It just is, for example, in diabetic nephropathy, you have a genetic thing, uncontrolled diabetes. By itself, controlling diabetes is not enough to prevent diabetic nephropathy. By itself, genetic predisposition is not able to cause diabetic nephropathy. So you may have multiple factors interacting, and then now you have factors which are our exposures, which are interacting among themselves in order to cause the disease. You can have alternate factors. You can have one or the other factor. Glomerular diseases are examples of like that. You see the genetic version of it, drug version of it, infectious version of it, autoimmune. All of these are sort of, you can have a given disease, membranous nephropathy, due to multiple different causes. And at that point, you see membranous nephropathy and say, hey, what is my cause? It becomes very difficult to isolate a single cause. And the final version is it can be even more complex, meaning thereby you can have multiple exposures. You can have exposures with additional risk factors, which by themselves are of no consequence. For example, let's say in amyloid disease, age by itself doesn't have anything to do. But if you have a secondary amyloid disease, the longer your disease has stayed, the greater the probability of secondary amyloid. And so you may have risk factors that are attached to it. And then you also may have interaction. Interaction means you have two sort of relatively innocuous type of insults. And then when they come by themselves, they don't have much effect, but together they can have a more than additive effect, which causes the disease even worse than either of them being there individually. So you have a lot of different ways of doing it. And this simplistic representation, actually a more complex version of this, works for most chronic diseases. So how do we, in such situation, ascribe causality? So our scientific brethren and the sisterans have established a way to say, how do we establish this? So they say, hey, if you have a hypothesis, go through these T0, T1, T2, T3, T4 translational time and prove through each step that your hypothesis stands true in either in vitro cultures, your animal studies, your human studies, the larger human studies and populations, right? So that's how the T1. Unfortunately, and most of the time, NIH has taken, or the scientific community has taken, a linear view of this, meaning thereby you usually start on the basic science and come back on this. The problem is that most of the time, discoveries don't go linear. So it is very common, and in fact, it is a very commonly stated sentence, right? That epidemiological studies are not causality establishing studies, they are hypothesis generating studies. So in recent time, we have seen PPI and CKD, right? This is just out of epidemiology. So now people are working backwards to figure out how PPI causes CKD or worsens CKD. Dr. Shah has a brilliant observation on SGLT2 being able to address hypomagnesemia in both diabetes and non-diabetes. These are exciting case observation and some small studies. We are now he's planning to go back and look at it from the animal model and say, hey, what does it really happen, or am I just seeing something flunky here? So we do this all the time. We go back and forth. I myself have a whole research where a drug has been there for 80 years. And now I think it's causing benefit in cardiovascular disease. So we did animal studies, and now we are trying to do human studies on that. So this is not a linear paradigm. And so we have to understand when you look at an evidence, what does evidence suggest? This pyramid is not about the significance of the research. The pyramid is about what findings and what is the strength of the finding with reference to application in human diseases. Significance of research is separate from this. But if you have an in vitro and animal study and you say, hey, I got my evidence, let me go ahead and apply it in humans, might be opening yourself up for malpractice. So you need to proceed through a various sort of stages to the lowest level of evidence is editorial or expert opinion because we all are biased. Case series, case control studies, randomized control trial, and then systemic reviews or systematic reviews, which are off randomized control trial, because no randomized control trial, largely, there has hardly been randomized control trial, which take care of all confounding and covariates. So, considering that this is our background knowledge and this is the spectrum with which we are going, let's see, can we take our question and provide an answer to the problem that we have? PD versus HD, did we do randomized control trial? And the answer, short answer is yes, we tried. This is the Netherlands group, which did it at the turn of the millennium, tried to enroll people and approach 1,200 screen patients, 770 approach. And out of that, 735 told, please get lost. I'm not going to let you flip a coin for me to go one or the other dialysis. You tell me what this dialysis is, I will choose one. Only 39 or 38 people said, okay, I'll let you flip a coin and whatever your coin says will do. So as you can see, there are very few people who ever got randomized. And I think this was a very important study. It has close to 800 citation. Imagine for a study that has no conclusion, 800 citation is great. Okay, and the reason why it has is it once and for all proved, at least till now, that we are never going to do a randomized control trial. So if you go back to my pyramid, you are not going to have a randomized control trial. So you are stuck with a cohort study. And hence our back and forth debate about which one is better. Okay. Go back to this. We are in a simplistic version of the chronic disease, right? So causality requires either direct or indirect exposure and proving. And most chronic disorder may have that second version of it. Now, there are two ways these factors can work. You can have a factor that may work as a mediator, which means in order for me to take a decision, I have to increase my knowledge, for example. Increasing knowledge becomes a mediator. Knowledge itself becomes a mediator to decision. Your intervention at that point can be an education, for example. I'm not going to be talking about that. I'm just telling you. That is how you can envision a mediator. Mediator is a mechanistic intermediate which resides between an exposure and an outcome. Without that, you may not have outcome, or it is critical component of it. The other problem is you can just have an intermediate step, right? So you provide me education, I take a decision, but by the way, I have somebody in the family who sort of moved out and now I'm living alone. I don't know what decision to take. My decision is influenced by that no matter what you do here. And so those intermediate likely don't have, they can work as a confounder or covariate, but they likely don't have any mechanistic role in the middle in terms of intervention to outcome. So what we are interested is this. There are various things that affect this relation. One is moderate, which means your exposure can have gradation. You can change the degree of exposure, that will change the degree of outcome. If you can do that, you have a higher confidence. None of them by itself will prove anything. But if your exposure and outcome can work in a graded fashion, it gives you a level of confidence. So the second is.
But are you talking about like a dose response, or you're talking
Yeah.
about effect modification?
So moderator is a dose response thing. So basically, your exposure can be considered as a dose response thing, and the moderator, your effect will or outcome will change based on that, based on a priori hypothesis. The covariates are the individual factor, like I told you in the recent example. Someone moving out of my family and I now living alone impacts my decision making. It didn't impact my ability to get education. It just impacts my decision making. Covariate is something that independent of exposure impacts outcome. The confounder does both, right? So for example, sometimes in race and ethnicity studies, both exposure and outcomes are influenced by the primary event. And all of these are largely, they cannot by themselves prove causality. And this is the limitation of epidemiological study. Against this, and this is not what we are interested in. We are interested for today's purpose of causality. What we want is to identify something which is directional, which occurs between the exposure and outcome. It is participatory, which means it works in the axis from leading from exposure to outcome. And it is causal, which means it is that event that causes the outcome. And how do we decide that? So in epidemiology, over the last 2 decades, people have recognized this and they have said that, hey guys, if we are going to talk about epidemiology, because this is the most common error in epidemiology. The most commonest error in epidemiology is we do epidemiology and we describe association, but we ascribe causality. And this is so prevalent that you will see for nearly every major epidemiological finding. When there is an editorial, they will critique the author for avoiding causality. And then the editorial will come back and ascribe causality with some caveat. So it's very, and if you read enough studies, you will see that this pattern repeatedly keeps on happening. We want to, as aspirational and enthusiastic people, we want to ascribe causality as often as possible. And normally we do this with everything, right? We have new. This on the web. Okay. So we do this with new invention, like, rituximab came. We all wanted it to work on everything. So we see one finding, don't know whether it worked because of that or not. We say every glomerular disease works for that. And now with the expanding oncology, we want to have almost every drug that comes out. We figure out some pathophysiological link and we want to say, my God, this is going to work. Right? So, but if you really want to truly establish this, you have to follow some principles. So the these are the principles that you are supposed to follow. Temporality, I described that, is the cause and the effect is the mediator, is between the two. It's temporally associated. Plausibility, you have to be able to explain people, and there can't be major refutation of your primary concept. Doesn't mean that your concept does not have covariates or confounder, but people should agree on the basic fundamental that mechanistically these are, or you should have enough data that mechanistically these are important enough to be considered. Consistency, meaning thereby both consistency and, So can you show it in various different ways? Like, just don't give me one random finding. Can you show me the same finding in an alternate population, which also works on the similar pathophysiology that has the same trends, so on and so forth? Strength, what is the strength? We always go with that. I think we go with all those statistical mumbo jumbo we do, confidence intervals, the effect size, hazard ratio, odds ratio, p-value, all of these, that all goes towards dose response. Like I said, that it is essentially if you change the exposure or the mediator's intensity or quality, can you replicate your finding as you would hypothesize with those changes? Obviously, reversibility in our chronic disease, that seldom works, so that's okay. And then evidence is study design and evidence for now are the later parts, so I'm not going to go into.
Can I ask a question?
Yes,
Where would you put reproducibility? Would you put somewhere?
the strength of the evidence or strength or the last part, how many lines of evidence leads to
Okay.
conclusion?
Makes sense.
So yeah, you can't have a random off thing as your primary conclusion. And at least you can publish it. Nobody would believe that there is a causality in there. Okay, so let's come back to our primary discussion. And for the lack of better word, I'm going to state the obvious, which dialysis is better, okay? This is a question I've been asked at least 1,000 times. So I'm going to go ahead and end with that question again. Okay? I'm not going to answer it. Okay, so my question to you is, now that you have heard all the things that I have told you about chronic disease, do you really expect, should we really expect a difference in outcome with dialysis? This is McFarland actually about 22 years back published this in Seminars in Nephrology, very loosely written article. He was just sitting there and just, it's a very philosophical article. And he basically said that generally, and this is cutting it off, by the way, my apologies. It says that this is PD and in-center hemodialysis, this is short daily hemodialysis, nocturnal transplant, so and so forth. And that's the fraction of your total renal function that these renal replacement therapies are giving you. If you are all at that level with PD and IHD, why are you saying this? And people have argued through wonderful, various different ways that, oh, I think it's different on this side or that side, small solute, phosphate, cardiac effect, fluid balance, all of those things. But generally speaking, that's where you reside. And we know how mortality exponentially rises as CKD progresses. So a majority of your mortality contribution comes in the early to mid CKD. So in the late CKD with that level of clearance, are we doing that fundamentally different treatment that it is going to change mortality? And again, I'm staying out of transplant. There is an argument that we may be able to discuss transplant in a different way. So the question that primarily we should be posing ourselves is, what are all the factors influencing mortality or survival on dialysis? And what is the influence of individual factor along that axis of life? It is almost never appropriate to ask a cross-sectional question, right? It's always, the question is, what all happened in patient's life and which one of them are important? And you can never answer them by a single cross-sectional study. You can if the impact is big. For example, aspirin and myocardial infarction. Number needed to treat are what, 4 or 7? That you can answer. This, as we saw, are very close to each other. The number needed to treat are going to be thousands. It's very difficult to answer. So let's see what are the factors, limited factors influencing an ESRD patient outcome, okay? This is what happens before a patient reaches you. They have gone through their majority of life insult through social determinant of health, development of comorbidity, diagnosis of comorbidity and ignorance of it, clinical care of comorbidity, non-nephrology and primary care, and development of CKD. If I ask all of you, are these things important for ESRD mortality? Almost every one of you will agree. Yes, we are not the only one managing the patient. Yes, patient is managed outside, and these things carry burden. Every 4 out of 5 patients with stage 4 or 5 CKD dies before they reach dialysis. So these are all important things. The person who is reaching ESRD is a lucky guy who survived through all of them. This is where we get involved. Diagnosis, nephrology provide option, and finally patient uses their dialysis. Okay? And what we are saying is that this one axis, we can dissect and we can give you answer. To me, that sounds very overconfident, let me call it that way. Because there is a bunch of things happening before that. And so what's happening is that survival is influenced by all of these things, but we are only focused on that last pathway. And that's very difficult to answer. This is the reason why the confusion of the entire axis is contributing to your variable outcome. So some studies are saying this is great outcome, PD is better, some studies say no, HD is better, some studies say, oh, it doesn't really matter in diabetes, this happens, CHF, this happens, so on and so forth. So today I'm going to try and see if I can talk about these highlighted versions, okay? And I'm going to give you some result, not too much, not go into details. I'm not going to go into the methodological aspect of it, but I'm going to give you this last pathway. But if you just don't mind hearing me, one more disclaimer here. I have just given you patient journey. Your SGLT2s and beta blockers and ACE inhibitors don't even feature yet. I have just said how the patient travels. There is a whole set of evidence-based practice that we do, which compiles on top of this to influence outcome. So when I do this, what I'm trying to do is I'm trying to pick something clean that I can articulate and identify and see if I can figure out that way whether there is an influence or not. That doesn't mean these are the only factors responsible. Okay? Okay, so now let's talk first about this. The pre-dialysis care. I'm not talking about any quality right now, just care and outcome. We know for a fact this is a well-described list. Oh, sorry, the dialysis modality. This has been well described. And I think we presented a part of this concept in the research round where we showed that how this will work. So I'm going to use two examples. So first example, I'm using this. So this is the first. And the second one, I'm going to take the same concept and actually start with what we actually started with, which is we wanted to examine the impact on mortality. Okay, so this is, again, we are trying to focus on this. We are trying to figure out exposure, mediator, outcome. This is the directed acycle graph that we are going to work with, okay? And this is just to anchor everybody. We are going to do racial disparity as an exposure and pre-dialysis care as a mediator. And I have presented this, but I'm just presenting this again, just to identify, just to anchor everybody on the graphs here, okay? So upstream cause is pre-dialysis care, pre-dialysis nephrology care, right? Oh, sorry, the race and disparity. Remember, I gave you the entire circle before that happened, but I'm just picking one of those factors. Nephrology care is a second factor and we all, I think, agree that nephrologists play important role in people starting home dialysis, or we are causal factor on this. That is just a hypothesized one, no proven, just hypothesized. But we think basically who we are, such smart people, that home dialysis doesn't happen without us. It's very uncommon, or at least the rates are going up. So that's the hypothesis by which we are going. And so what we are trying to say is that how or to what extent an upstream determinant of health outcomes can be explained by a more proximal factor, which is nephrology care. And then this is the mediation analysis. You do it, you examine the exposure to outcome direct impact, exposure to outcome through mediator impact, and seeing the difference between the two. You can argue that the difference is driven by mediator as long as there are no significant interaction, quote unquote, a confounder. Mediator does not behave as a confounder. As long as that's the case, you could say, okay, we can do something about it. Okay, so again, going to this particular axis, I don't know why this came again, but so this is the one that we published in JSON, and essentially we say that pre-dialysis nephrology care, disparities in pre-dialysis nephrology care is responsible for about 30% of home dialysis underuse amongst Hispanic individuals, about 15% in Black individuals. which means they get less nephrologic care, they get less home dialysis, and the fact that their nephrology care is lower contributes about 30% of it. There are other factors contributing for the remaining 70% of it. We currently have this paper in consideration where we are doing the similar thing for vascular access. About 30%, 33% of vascular access disparity among Hispanic individuals. I have the data for the Black individuals as well, but it's related to their not being able to just see nephrologists. There may be other factors contributing to the next remaining 70%. Okay, so this is not what I want to talk about. So this is the past. And this is what we presented. And what we tried to show from that is one, how this model works. And two, we basically say that if you are talking about the incident vascular access and incident home dialysis problems, your system-based access to care factors may be contributing about a third of the problem. That's your area to address. You can address one area and you can address about a third of your problem going forward. Now we want to do is, so this is what we described, and now what we want to do is, what is the impact of dialysis modality on survival? Okay, so this is the danger zone that you don't want to enter. So we, like you saw that entire mapping, we are progressing along our mapping graph. Now we are saying the exposure. We no longer are in the realm of race and exposure. We are just saying pre-dialysis nephrology care as exposure. Incident outcome. We all know pre-dialysis nephrology care is associated somewhere between 4 to 10 times higher rates of home dialysis and incident vascular access. So, and there have been enough hypotheses thrown out that both incident vascular access and home dialysis improve survival on ESRD. I'm making it a more cleaner statement. This is all associated with. So, but there has been enough discussion from that. So we want to try and see, is that true? Okay. So, and then we control for the regular things that people control for in these sort of analysis. This has been done by others before. Some of it has been done by, we have done some of this paper, but essentially pre-dialysis nephrology care to incident ESRD parameters, home dialysis utilization, AVF, AVG composite measure, incident maturing AVF, AVG, and then SOL CVC. And what you can see is that if you have nephrology care, you have about 4 times higher home dialysis, 7 times higher composite AVF, AVG, 2.5 times higher maturing AVF, and you have a quarter of a chance of starting dialysis with vascular access, CVC. So that is that one axis we are proving. In the second one, we are saying pre-dialysis nephrology care to survival. So people who have dialysis, pre-dialysis nephrology care, how they survive on dialysis. And what it shows is, and these are 2 separate analyses, so I'm just showing you that there is somewhere around a quarter. Hazard ratio goes down by about a quarter. So the mortality is about 3/4 of that of those without nephrology care. And then finally, how do these are just the associations. This association is what I showed you on multiple other publications from past. What does it show? In our all adjusted model, home dialysis compared to in-center dialysis, 26%. This we have truncated the analysis at 3 years because the presupposition is that your pre-dialysis care only influences early mortality. Again, you can't draw this out forever because given infinite time, all interventions are useless. Everybody's going to die. So what we need to do is we need to try and isolate where the impact is likely to be. And so what we're doing is that this is a 3-year, we are going to do 1, 2, and 3 year mortality. So we'll give you a trend or something. But essentially what I'm trying to say is that home dialysis compared to in-center, 26% lower mortality at 3 years. And when you break down the in-center into AVF, incident vascular access versus not having incident vascular access, you see that the trends flip in incident vascular access. There is, if you have mature AVF, AVG, it's not really helpful. In fact, this particular analysis suggests that there may be some harm versus those who don't have AVF, AVG or have maturing, you actually have mortality benefit. Now, a part of this is who gets AVF, AVG done, so on and so forth, and all the limitations go with that. This is just the lower table is compared to AVF and AVG, mature vascular access. How does it do if you don't have mature vascular access? And you see this, if you have maturing vascular access, you have 20% low, compared to maturing vascular access, you have 20% lower mortality. Compared to CVC, you have 56% lower mortality. And this has been shown before. I'm not saying that it will be here. So this is what we were trying to do. How much of this is related to doing home dialysis? And what we found was, and I think this is what it is, that even though home dialysis shows significant survival advantage, early survival advantage in an adjusted analysis, the attributable influence of this on the improved survival related to pre-dialysis nephrology care is not much. It is still significant. The P is still less than 0.01, but it's about 7% mortality advantage. So we saw that there was some flip going on in this thing, and there is some data error here also. So bear with me, but the message is not incorrect. We examined for those who have AVF, AVG versus pure CVC. And we found that the actual benefit, if you start with PD versus AVF, AVG, as you look at your pre-dialysis nephrology care survival advantage. So remember, this is all in the context of if you have nephrologist, you survive longer. And you are interjecting with modality. And you are saying, which part of that behavior is contributed by your care or home dialysis? And here, compared to home dialysis, if you start with fistula or mature graft, you don't have much survival advantage. It's still statistically significant, but all of us would agree that's minimal enough that in a complicated statistical analysis, you really don't have that much left to stand on. Compared to if you start with pure CVC, the survival advantage, a significant third of your survival advantage is attributed to starting people on home dialysis. So finally, we examined just compared to AVF and AVG, like a mature access versus not mature access, what is the attributable influence? And about half of nephrology care survival advantage is contributed or attributed to having mature vascular access. Nearly half. That's a major thing. There is a concern going around currently in the ESRD world, and there is a very disturbing concern going around in ESRD world, where with the latest vascular access guideline and the shared decision-making guideline, a few of us, or about half of the population, is interpreting it as the Canadians had early sort of indication on this, that vascular access, CVC versus incident vascular access, there is no real mortality difference, at least in Canada. And so they have been driving this, and Europeans also have seen data in there. US has never been able to show that particular data, but the latest KDIGO guidelines sort of say right patient, right choice part. And so they say maybe vascular access is not as important for mortality. And I think what they're missing over there, and this is a very concerning thing, is that they are ascribing the illogical vascular access rationale to logical vascular access rationale, meaning thereby there is a population for which vascular access is detrimental, meaning thereby for people who are very high comorbidities, high age, unlikely to survive long, vascular access is an additional procedure. You may not drive any benefit. You actually may increase morbidity and mortality. Versus, there is a lack of care population for which vascular access is actually important. And I think the latest guidelines, while they don't explicitly sort of dissect this, the problem with their interpretation is that this interpretation is getting wrong. And we actually are going through some of this in one of our papers. So what I'm trying to say is that this is an important part. Plus, it is still a CMS NQF quality measure. You have to have incident vascular access. They want 65%. Oh God, no, we are less than 20%. So let me come to the conclusion, and the M. Night Shyamalan moment hopefully will come. So what I'm trying to say is that the length and quality of pre-dialysis nephrology care are associated with about half, 50 to 75% longer 1-year survival. This, my apologies, I didn't change this statement. We have a 1-year survival, 2-year survival, and 3-year survival. This is an old statement, and I forgot to change it. What I'm trying to say is that home dialysis contributes to only about 7%, but incident vascular access contributes to a much higher, or attributes to much higher survival advantage of pre-dialysis nephrology care on outcome. And then we have a bunch of sensitivity analysis. I'll show you some of the time. And so the entire analysis is just way too long for me to bring it here. So what I'm trying to show finally here is that we have only discussed this lower aspect, and that too in its limited form. We have not discussed the quality of care. We have not discussed what you talk to patient and how good you are versus a private physician or somebody like that. We have not talked about anything. We have just talked the bare bone discussion. But what we are showing is that there may be, that it is important to consider that outcomes are influenced by longitudinal events and not cross-sectional one-time event. That every time you evaluate the impact of an exposure on outcome, there are preceding and intervening events that influence outcome. So this is your concept, right? We all always have seen solar system, at least I have. I was not that smart, but throughout my life, I have seen solar system like this. That there is a sun, that let's call it truth for a second. There is a truth, and then there are things which are moving around it. And anytime you do these calculations, that you are looking at what combination of factors are arriving at what point to derive your truth, or whatever your, what is it called? The cancers and the Taurus, what are they called? Yeah, all of those signs, right? So you try and predict these based on that. My worry is that it actually is not true. As it stands, the real universe looks more like this, where sun itself is traveling on a trajectory, and everybody else is following. So everything that I told you today is what the data tells us today. These causal inferences are all what the data tells us today. Based on our today's action, we will change tomorrow's action. Based on our today's finding, we'll change tomorrow's action, which will again change the causal inference. And we have to continuously follow the truth to find the real-time causality for everything that we do. Okay, I'm going to stop here. I don't know whether it landed or not, but this, since it's astrology and whatever it is, so we are looking at the outer sky. This is our lab looking at the eclipse, trying to peek into that space of truth, and this is that last year's eclipse. By the way, the guy who is standing tall in the back is the primary guy who has done all the analysis. Grant, he no longer is with us; he moved already. But these are my. Okay, I'm going to stop.
That was an interesting, very interesting presentation. We got of course what you just said. When you talked about John Bergman, he wrote a few years ago in C. Jason. The title was quite fairly interesting. Survival by modality. Who cares? Yeah. Right. And at the end of the day, what they were saying, obviously, is that at 2 decades, as you said, 2 decades, 3 decades of studies, we would not know the answer to this. So let's go to patient-centered approach and see what the patient wants. Go with that and forget about which one gives better survival.
I think that's correct. And and just to latch on to that, and that's the reason why I don't want to talk about the modality as a survival. I want to juxtaposition our discussion to say pre-dialysis care is associated with survival. Modality is but one mean into this. And I think if we position ourselves like that, it makes the discussion more anchorable, sort of, if I'm using the right word. But yeah, I think point is well taken.
But I think it was 2002, 2003, Norbert Lemaire's group, I think it's when Van Diesen came
Yeah.
up with the concept of integrated renal replacement therapy
Yeah.
concept, saying that it's not a matter of this one is better than that one, it's a matter of each of the modalities have certain lifespan. So whether it's PD or HD cannot continue forever. So it's better to get use of both of them while the patient's waiting for transplant, which is the best renal replacement therapy, so to speak. And then based on that, they were saying that, okay, start with PD because PD will preserve your remnant kidney function, whereas if you start with HD and all that, and if for a few years, if you remember, it was very, well, every conference they were talking about that, I don't know, it just subsided. So the matter was that use it both modalities in every patient because not one modality can survive forever. So what is your take on that?
So I don't know whether all of you know Norbert Lemaitre or not. This was a great time of discussion. I met Norbert Lemaitre in Toronto when he visited. Great guy, by the way. We practice this, and I think I still practice a version of Lemaire's integrated ESRD care model. The problem with Lemaire's version, as well as the Aureopoulos' version in past, the Aureopoulos' version was not explicit, so it wasn't that way. And even Bergman, I worked with those guys, and I don't think they follow the Lemaire's version, but they use that version as effectively to promote their argument as they could. The problem with Lemaire's version was that the integrated care always was defined as you deciding what might be the beneficial aspect of this. So, for example, like you said, that let's use PD in the early phase because we think that it preserves residual renal function, and we think that is associated with increased or survival or decreased mortality. And so what we are doing good for the patient and patient can probably follow. I think my version, my current concept would be that Lemaire's version, integrated KRT practice is essential, but the integrated KRT practice cannot be paternalistic, needs to be patient-centered or shared decision-making, meaning thereby your role is not to promote a point of view. Your role is to present the data in its most honest form and let the patient make the decision because, and this is my long-standing hypothesis, that patient, while we have not shown any modality or anything to change mortality in ESRD, I do believe that the patient-centered therapy or selection of KRT probably will do it. That's my one
Explain
hypothesis.
to the patient, right? So if the theory happens to be true, you can tell the patient if you go through that pathway, there is a chance that you will live longer.
Right,
But the
but
patient decides. Obviously, you're not forcing the patient, but you give this information to the patient that this
absolutely.
is supposed to make you live longer.
Absolutely, except for the fact that I'm not sure that I would be able to make that statement right now with the current evidence. That one, PD preserves the residual renal function longer, or two, PD is associated with early or late mortality advantage.
So after understanding the presentation's complexity,
Thank you so much.
do you think we will ever have a strong enough evidence to assign causality between modalities that one increases mortality, understanding how complex it is? That, as you mentioned, we're not going to have randomized control trial ever, and all studies will have bias, whichever you pick on.
In the realm of current scientific concepts of Cox postulate and randomized control trial being at the apex of evidence-based medicine, it is difficult to presume how this will ever be resolved. It is potentially possible that as the time goes, our philosophy of what evidence-based medicine is changes. And maybe machine learning might play a role, some role there or not. I don't know the answer to that, but I think as long as we are married to the Cox postulate and randomized control trial, which currently we are very strongly married to, it's very difficult to suspect that this is going to come here.
I mean, don't you think that maybe then a corollary of this is you could do a randomized trial of like a public health initiative to increase access to early or pre-dialysis care
Mhm.
for populations you've identified as being at great risk, and do a randomized trial of that and then look at survival.
There you go. So that's my thought. That's the grant we are working on. I don't think that it's going, that's the third grant I can do, not right now, but hands down, I think that's the. And again, people will argue there would be problems with that trial and there would be caveats, but yes, I think
It won't be an explanatory trial, it'd be a pragmatic trial.
it will be a pragmatic trial, and even at the end of that, what you are doing is that let me use a stupid word, but that it will be an oxymoronic trial whenever we propose that, hey, providing more care leads to better outcome. And I think I sometimes get into this and like somebody just points out, a reviewer points out, oh, come on, that's not fair. And I'm like, so the good thing about the whole science right now is that we have realized that we have been doing that pyramid wrong over the last 30 years. So NIH, VA, or everybody is trying to focus more and more on clinical and patient-centered trial. So I think hopefully, because that's the real world evidence that we need to actually say what we do influences outcome, not what happens in a lab.
It's all about money, right? It's all about what you're gonna spend your money on,
Yeah.
right, to affect outcomes,
Yeah.
right? End of the day, and so if you wanna make the case, sure, obviously getting better care
Mhm.
will lead to better outcomes.
There you
right?
go.
But what kind of care and when?
Yeah.
Right, and where to direct your money, I think is the selling point.
Yeah, and I think, yes, you got in the arc of government disposability. So I don't know whether that trial is going to happen or not, but I think the implementation science is sort of coming up in a big way. That all of these random things that we all pick up, nobody actually goes and does it to the patient, and I think now we need to do more and more of that.
Thank you very much.
Or the-
Yes.
How many does it look like?